Dr. Areeba, are you ready to present?
Yes, sir.
Somebody in your group needs to unmute themselves. You have an echo. So I welcome you guys again to another session of the Residence Corner module. These sessions are arranged by the Department of Neurosurgery at Liaquat National Hospital, and the idea behind these lectures is to build a 3D neuroanatomy, which is very important for any neurosurgeons. The topic of our presentation today is PICA. Dr. Areeba is AFO resident at Liaquat National Hospital. Our expert panelist today is Dr. Misbah. Dr. Misbah is interventional radiologist at Liaquat National Hospital. He will be joining in a couple of minutes. I urge you all to be inquisitive. These sessions are for you. You can use the chat box at the end if you want to ask questions or in between. So, Dr. Areeba, can you start your presentation?
Yes, sir. Assalamu alaikum, good morning. So today we will be continuing our section of posterior fossa arteries. Last week we have done superior cerebellar artery, anterior inferior cerebellar artery, and this week we will be doing posterior inferior cerebellar artery. So this picture is familiar to all of you by now, and we have done this multiple times. So we studied upper complex in SCA, middle complex in ICA, and today we will be discussing PICA. So as we have discussed previously, the best way to study posterior fossa arteries and anatomy is to divide it into complexes, an upper complex, a middle, and a lower complex. So each complex has its own artery, its own surface of the brainstem, its own cranial nerves, its own fissure in which it's going to run, its own cerebellar peduncle, and a surface of the cerebellum that's going to supply. So today we will be dealing with PICA, and automatically we will be dealing with lower complex. So the main artery of lower complex is PICA, which is the main artery which we are going to do today. It will be associated with medulla of the brainstem, just as ICA was associated with pons and SCA was associated with midbrain. The cranial nerves that are going to be associated with PICA are 9th, 10th, 11th, and 12th. The fissure that's going to run in it is cerebellomedullary fissure, as it's going to be associated with medulla. So it's going to be running in cerebellomedullary fissure. And the cerebellar peduncle that is in the close proximity with it will be inferior cerebellar peduncle. And the surface of the cerebellum that's going to supply is suboccipital surface. So let's move forward with PICA. So the PICA is intimately related to cerebellomedullary fissure, the inferior half of the ventricular roof, the inferior cerebellar peduncle, and the suboccipital surface, as we saw previously. The PICA by definition arises from the vertebral artery near the inferior olive and passes posteriorly around the medulla. At the anterolateral margin of the medulla, it passes rostral or caudal or between the rootlets of hypoglossal nerve. It can vary. And at the posterolateral margin of the medulla, it courses rostral to or between the phyla of glossopharyngeal, vagus, and accessory nerve. As we have discussed previously, that PICA is going to be associated with 9th, 10th, 11th, and 12th nerve. So after its origin, it's going to be passing in between the fibers of these nerves. After passing the lateral nerves, it courses around the cerebellar tonsil and enters the cerebellomedullary fissure. like we discussed previously, that is going to be, the pica is going to be intimately related to the cerebellomedullary fissure and passes posterior to lower half of the roof of the fourth ventricle. On exiting the cerebellomedullary fissure, its branches are distributed to the vermis and hemisphere of the suboccipital surface, the surface of the cerebellum that's going to supply. As we discussed previously, the SCA supplies the tentorial surface of the cerebellum. The ICA supplies the petrosal surface of the cerebellum. And the PICA is going to supply the suboccipital surface of the cerebellum. So starting with simple dissections, as we can see here, it's a diagrammatic illustration of the anatomical correlations of the pica. We can see the two vertebral arteries joined together to form the basilar artery. And as we can see, the pica arises from the vertebral artery. This is the right side and this is the left side. So as we can see, the colored parts are the segments that we are going to discuss later on in the same lecture. This is going to be the pica. This is a segment 1, 2, 3, and a segment 4. And then it's going to supply the suboccipital surface of the cerebellum by dividing into multiple small branches. As we can see, during its course is associated with branches of the hypoglossal nerve, the branches of 9th, 10th, and 11th nerve. Again, a different view. Coronal image showing you the same diagrammatic illustration, showing the origin of the pica from the vertebral artery. Its course, it's basically the most tortuous artery that is present in the posterior fossa. So we can see how it's making many different loops and then supplying the suboccipital surface of the cerebellum and how it's closely associated with tonsils. We will be discussing these diagrams again later on. Again, a diagrammatic illustration showing origin of pica from the vertebral artery. It's division into multiple segments and then it's going to supply the suboccipital surface of the cerebellum. So what are the segments of the cerebellum that we are, segments of the pica that we are discussing? Just as we did in SCA, that it was divided into 4 segments, and we did in ICA that it was divided into 4 segments. The pica is basically divided into 5 segments. So the name would be the anterior medullary, lateral medullary, tonsomedullary, tilo-velo-tonsillar, and cortical. So as you can see the pattern that the last branches of all the SCA, ICA, and PICA are cortical. And the first 2 are usually anterior and lateral. So they were anterior pontine, anterior lateral pontine in ICA. They were kind of like anterior pontomesencephalic and lateral pontomesencephalic in SCA. So they will be anterior medullary because they are associated with medulla oblongata in PICA, and lateral medullary in PICA, which will be the P2 segment of PICA. 3 and 4 are a little bit different. So segment 3 will be tonsillomedullary. That is the part of the pica associated with tonsils and its junction with medulla. And the segment 4 will be tilo-velo-tonsillar. That is the segment of the pica which will be associated with tonsils and tilo-velar segment. So let's move on to each segment one by one, starting from the anterior medullary segment, that is P1 segment of pica. This segment lies anterior to medulla. As the name suggests, anterior medullary will be anterior to the medulla. It begins at the origin of the pica anterior to the medulla and extends backward past the hypoglossal nerve roots to the level of a rostrocaudal line, the most prominent part of the inferior olive that makes the boundary between the anterior and lateral surface of the medulla. A better picture to understand it would be this one. So as you can see, the part of the pica that is labeled green is the P1 segment, and it's anterior medullary segment because it's anterior to medulla and it's going to run laterally. There will be an imaginary line running from the lateral border of olive that will divide it into anterior and lateral medullary segment. Again, we can see anterior medullary segment arising from the vertebral artery present in front of the medulla oblongata. The nerve roots that are closely associated with this segment will be the hypoglossal nerve roots. Coming up next, so these picas, that is anterior medullary segment, arise lateral. Those picas that arise lateral rather than anterior to medulla do not have an anterior medullary segment. As we know that the anatomy of fossa is quite variable and the anatomy of pica is also quite variable. So in some dissection, it was seen that pica was not arising from the vertebral artery anterior to medulla, but was arising lateral to it. So if we have a different anatomy and pica is arising from vertebral artery that is lying lateral to the medulla oblongata, then we won't have this anterior medullary segment. An anterior medullary segment is more likely to be present if the pica arises from the superior part of vertebral artery, because the vertebral artery courses from the lateral side of the medulla below to the anterior surface of the medulla. An anterior medullary segment is present in the vertebral artery at the level of origin of the pica, has passed to the anterior surface of the brainstem, which makes sense. So coming up next, part 2 or P2 segment is the lateral medullary segment. As the name suggests, it will be running lateral to the medulla. So this segment begins where the artery passes the most prominent part of the olives and end at the level of the origin of the glossopharyngeal, vagus, and accessory fruitlet. Again, a better picture, simpler picture to understand this would be this one. The orange segment is the P2 or the lateral medullary segment of pica. As we can see, it starts from the part where P1 segment of pica ends, which is the most prominent part of the olive. And it's going to end where the 9th, 10th, and 11th nerve have arisen or their origin have begun. So this is a small segment, and it's going to run on the lateral surface of the medulla. So it's going to be running laterally. The third segment or the P3 segment of pica is tonsillomedullary segment. This segment begins where the pica passes posterior to the glossopharyngeal, vagus, and accessory nerve, as we discussed previously, and extends medially across the posterior aspect of the medulla near the caudal half. It ends where the artery ascends to the mid-level of the medial surface of the tonsil. So as we can see in this dissection, this is basically, we can see two vertebral arteries. We can appreciate the origin of pica posteriorly. We can see that the P1 segment will be running anterior to it, and P2 is running laterally. So P3 segment is the one which is going to be associated with tonsil, and it's going to make a loop, an inferior loop. A better way to understand this is this diagram. We can see P1, that is anterior medullary segment, P2, lateral medullary segment. These two segments are going to be associated with nerves. P1 is going to be associated with hypoglossal rootlets. P2 is going to be associated with 9th, 10th, and 11th nerve. Then P3 segment is going to run on the lateral surface of tonsil, and it's going to make a tortuous force. It's going to make a loop. We call this loop, this turn, a caudal loop because it's running caudally. It's going towards the caudal surface of the tonsil, and it's making a loop around it. So it's known as a caudal loop. When it's going to ascend back up and going to make another loop here, we will call it the cranial loop. We will see this later on. So this P3 segment ends where the artery ascends to the mid-level of the medial surface of tonsil. The proximal portion of the segment usually courses near the lateral recess and then posteriorly to reach the inferior pole of tonsil. This segment commonly passes medially between the lower margin of the tonsil and the medulla before turning rostrally along the medial surface of the tonsil. The loop passing near the lower part of the tonsil referred to as the caudal loop or infratonsillar, just as we have discussed previously. Let me show you again. This loop, this blue part, as you can see here, this is the course of the pica, which is basically how the pica is turning caudally or making a loop around the tonsil. So this loop is known as a caudal loop, and it's also known as infratonsillar loop of pica. It has been reported to form a caudally convex loop that coincides with the caudal pole of the tonsil, but it may also course superior or inferior to the caudal pole of tonsil without forming a loop. Caudally convex loop is not present if the pica passes directly, medially between the tonsil and medulla, if the pica ascends along the lateral surface of the tonsil to reach the hemispheric surface, or if the artery is a low origin from the vertebral artery and ascends posterior to the medulla to reach the tonsil. Again, this is, as we have discussed previously, that the anatomical variations are present commonly. So if the pica, this caudal loop won't be present if the pica is arising from the hemispheric surface or if it's arising from the lower origin from the vertebral artery. Now the P4 segment or the tilo-velo-tonsillar segment. This segment begins at the mid portion of the pica's ascent along the medial surface of the tonsils towards the roof of the fourth ventricle, and ends where it exits a fissure between the vermis, tonsil, and hemisphere to reach a suboccipital surface. So this artery is going, P4 segment is going to make a cranial loop, and it's going to end up in the cerebellomedullary fissure. This segment gives rise to branches that supply the tila choroidea and choroid plexus of the fourth ventricle because it's intimately related to the inferior wall of the fourth ventricle. Let's see this again in another dissection. We can see that P1 makes the anterior medullary segment, P2 lateral medullary segment. Then when it courses around the tonsil and form a caudal loop, cranial caudal loop, it's known as P3. And when it ascends back up and going to run in the cerebellomedullary fissure, it's going to be known as P4 segment or tilo-velo-tonsillar segment. We can see it here again. If we're going to remove the tonsil and we're going to dissect it out, we can see the course of P4 here. Very easy. Now the last segment is a cortical segment or P5 segment. As the name suggests, it's going to supply the cortex. And as we know previously, that the surface of the cerebellum that is going to be supplied by PICA is suboccipital surface. So it's going to branch on the suboccipital surface of the cerebellum. So this segment begins where the trunks and branches leave the groove between the vermis medially and tonsil and the hemisphere laterally and includes the terminal cortical branches. The bifurcation of the PICA often occurs near the origin of this segment. So as we can see, P1, P2 will be present anteriorly and laterally, P3 run here, P4 run in the fissure, and P5 is going to supply the suboccipital surface of the cerebellum. Now let's move on to step-by-step dissection given by Roton so that we can understand the anatomy better. As we can see, we can appreciate two suboccipital surfaces of the cerebellum. Here we are viewing from inferiorly. You can see that two vertebral arteries, like this will be a posterior-anterior orientation. This is going to be the left side of the patient and this is going to be the right side of the patient. We can make it up like two vertebral arteries will be running like these, and then they are going to join together. They will form the basilar artery. So as we can see that PICA is running on the suboccipital surface. We can't appreciate a whole course of the PICA, so we are going to dissect out one by one. So as we can see, here we can see the vertebral artery. I hope you can see my pointer. So as you can see, this is going to be the vertebral artery. We can see the origin of the PICA from the vertebral artery. We can see that this segment that is going to run anteriorly would be the anterior medullary segment. This will be the P2 segment, and then that part that is associated with tonsils and going up will be the P3 segment. If you are going to remove this tonsil so that we can see a better picture, we can easily understand that this is uvula. We have removed the tonsil and we can see the tila part over here. We can see the fourth ventricle here. We can see that PICA is arising and it's going to run a tortuous course behind the tonsil. Another dissection here, they have dissected uvula from here and have retracted it downward. So this is a part of the uvula that's going to be attached, and this is the part of uvula that has been dissected or retracted down here. So we can see the course of the P3 segment of the PICA that is present behind the tonsil and in the cerebellomedullary fissure. Again, looking at it from lateral view or sagittal section, we can see this is the cerebellum and this is the brainstem. In easy words, we can appreciate the superior peduncle, the middle cerebellar peduncle, and we can appreciate the inferior cerebellar peduncle. So PICA will be associated with inferior cerebellar peduncle. So we can easily pick out that the artery that is present closely with inferior cerebellar peduncle is the PICA. We can see that it's closely related to cranial nerve 9th, 10th, 11th, and we can see that it courses further somewhere here, and it's then going to emerge from cerebellomedullary fissure. And we know the component, the segment of the PICA which runs in the cerebellomedullary fissure is P4. And after running here, it will run on the surface to supply the suboccipital surface of the cerebellum. Again, similar dissection. Now we have dissected out some tissue. We have dissected out nodule. We have dissected out peduncles just to give you a better picture of the course of PICA. Again, similar diagram, but better dissection. We can see this is going to be the middle cerebellar peduncle. The superior cerebellar peduncle will be somewhere here, and inferior peduncle would be somewhere here. We can see this is PICA. The segment that will be anterior to medulla will be P1. This will be P2, lateral segment. Then it's going to run laterally, and the part where it's going to run in this part where it's going to run in the cerebellomedullary fissure will be P4. It's going to make a caudal loop here, it's not visible here, and then a cranial loop. This is a cranial loop. And then it's going to supply the suboccipital surface of the cerebellum. Similar dissection. Now we have dissected out the tonsil. Just to give you a better view, we can again see PICA. We can appreciate it going down. We can appreciate it in cerebellomedullary fissure. We can see let's make a caudal loop here near the tonsil, lower caudal loop, and then it's going to run upward and make a cranial loop. This is a cranial loop. As we can see, after making a cranial loop, it's again going to bend down and supply the cortical suboccipital surface of the cerebellum. Now this is a close-up view of the PICA and its association with the floor of the fourth ventricle and tila choroidea. So as we can see that PICA running laterally to the tila choroidea. This is lateral recess, and as a name, as we previously studied, it's going to give branches to the tila choroidea and choroid plexus of the fourth ventricle. So it makes sense that it's closely related to it. Now, moving forward, now there are commonly some variations that are found in the course of the PICA. As we have discussed previously, it has a very tortuous course and it gives on many branches. Sometimes there is tonsil and there is caudal loop that is associated with it. The course that we have commonly seen is this blue one, that is tonsil, caudal loop associated with caudal loop of tonsils. But sometimes the origin of PICA from the vertebral artery differ. So the loops can differ. Sometimes the caudal loop won't be that caudal, just like this orange one. And sometimes the caudal loop will be very caudal and running inferior to the tonsil, just like we have seen in this green loop. So these variations can be present. If we are going to associate it with foramen magnum, so as we can see, this is where the base of skull is present, and this is the foramen magnum. So sometimes the loop is present much superior or much above the foramen magnum. But sometimes it passes the caudal loop of PICA just touches the foramen magnum, and sometimes it passes in through the foramen magnum and into the spinal cavity. Similarly, the cranial loop course differs. Sometimes it's the normal course of the cranial loop is that it's going to run laterally towards the upper pole of the tonsil, but sometimes it can run much superiorly or much inferiorly. So let's study about the origin of the PICA. As we have done in previous lectures, we start with the segments, we go with origin, then bifurcation, and then segments of the arteries. So we have done segments of the PICA. Now, what is the origin of the PICA? So the PICA generally arises from the vertebral artery, but may arise from the basilar artery. If the PICA is present, it is the largest branch of the vertebral artery. It is rarely absent bilaterally, but may arise as a double or duplicate PICA. The vertebral artery enters the dura lateral to the cervicomedullary junction. Course is superior, anterior, and medial to reach the front of the medulla and joins its mate from the opposite side at approximately the level of fontomedullary junction to form the basilar artery. The site of the origin of the PICA from the vertebral artery varies from below the foramen magnum to the vertebro-basilar junction. So it can arise anywhere. A few of the PICAs arising below the foramen magnum may arise from the vertebral artery in an extradural location. As we can see in this dissection, we know that normally PICA arises from the vertebral artery, but it's an intradural course. But sometimes it may arise from an extradural origin. As we can see, this is a vertebral artery, and this is the limit of foramen magnum. And as we can see that the PICA is arising extradurally. So there's an extradural origin of PICA. Here again, another dissection showing a vertebral artery here and going here, and the origin of PICA, which is extradural, outside the skull. So how does it bifurcate? Most PICA bifurcate into a smaller medial and a larger lateral trunk. The trunk before the bifurcation is referred to as the main trunk. And the most common site of bifurcation is the tilo-velotonsillar fissure, as the artery courses around the rostral pole of the tonsil. So, as we have seen multiple times, this tilo-velotonsillar segment, the P4 segment, here behind the tonsil, this is the common site of bifurcation of the PICA into two. Now moving on to branches of the PICA. The PICA gives rise to perforating branches to the medulla, the part of the brainstem it's associated with. Choroidal arteries that supply the dila choroidea and choroid plexus, because as we saw, it's very closely related to fourth ventricle, and cortical arteries. And as the name suggests, cortical arteries are going to be supplied to suboccipital surface of the cerebellum. The cortical arteries are divided into median and paramedian, Wormian branches, tonsillar branches, and medial, intermediate, and lateral hemispheric arteries. We are going to discuss these later on. So as we can see here, we are going to do a step-by-step dissection as given by Rotron. We can appreciate the two PICAs here. As we can see, they are running laterally in the cerebellomedullary fissure. They are going to run around the tonsil, making a caudal loop, then a cranial loop somewhere here. After removing the tonsil, after removing the retracting the cerebellum, we can easily see the PICAs here and here running laterally, making a tortuous course, making many loops, and running lateral to the lateral recess, supplying the choroid plexus and tila choroidea. Again, these are the PICAs dividing into medial trunks and further later on into lateral trunks. Again, PICA divided into a medial trunk, later on a lateral trunk. So we can see this on the surface of the lateral to the fourth ventricle is the medial trunk, and this is that is going to run laterally is the lateral trunk. Here we can easily appreciate the anatomy of the floor of the fourth ventricle that we have done previously. The choroidal arteries, the PICA give rise to branches that supply the tila choroidea and choroid plexus of the fourth ventricle, usually supplying the choroid plexus near the midline of the roof of the fourth ventricle and in the medial part of the lateral recess. The ICA usually supplies the portion of the choroid plexus not supplied by the PICA. Commonly, that part in the cerebello-pontine angle and the adjacent part of the lateral recess. Now the cortical arteries. The most constant area supplied by the PICA includes a majority of the ipsilateral half of the suboccipital surface of the cerebellum. The cortical branches are divided into hemispheric, Wormian, and tonsillar group. As the name suggests, tonsillar group is going to supply the surface area of the tonsil, vermix, and the hemisphere, cerebellar hemisphere. The Wormian branches usually arises from the medial trunk because it's present medially, and the hemispheric and tonsillar branches from the lateral trunk. Each half of the vermis is divided into a median and paramedian segment. It's just kind of similar like how the cortical branches of superior cerebellar artery were dividing into a Wormian branch and a paramedian segment. And the hemisphere lateral to the vermis is divided into medial, intermediate, and lateral segment. Again, this is similar to how SCA divides and supplies the tentorial surface of the cerebellum. So the hemispheric branches most commonly arises from the lateral trunk within or distal to the vermo-hemispheric fissure. They appear to radiate outward to the hemispheric surface from the superior and lateral margin of the tonsil. A common pattern is 3 branches, with an individual branch being directed to the medial, intermediate, and lateral segment of the suboccipital surface, just like SCA does on the tentorial surface of the cerebellum. The medial hemispheric segment is occasionally supplied by the medial trunk. The ipsilateral ICA often give rise to branches that overlap onto the lateral hemispheric segment, and the SC often overlaps on the superior part of 3 hemispheric segments. Moving on to Wormian arteries, which usually arise from the medial trunk. Common pattern is there are going to be 1 or 2 Wormian branches. If 2 are present, they are often directed against the median and paramedian segment, just like SCA. If no vermian branches are present, the vermian area is usually supplied by the contralateral pica. So if the right side on the right pica, if the right pica doesn't have any branch that supplies a vermian area, or the left side pica will be giving branches that will supply the vermis. The tonsillar branches usually arise from the lateral trunk and most commonly supply the medial, posterior, inferior part of anterior surface of tonsil. If there are no branches directly predominant tonsil, the tonsil is supplied by adjacent hemispheric and vermian branches. So it's not necessary that tonsil gets its own supply. Now moving forward, as we can see, there are two vertebral arteries, pica arising from the vertebral arteries, making a caudal loop, then a cranial loop. And then as we can see, it's going to supply the choroid plexus. Now, what is the clinical significance of studying the course of pica? Why are we doing this? The consequence of pica occlusion vary and may be overshadowed by the effects of occlusion of the parent vertebral artery. The effects range from a clinically silent occlusion to infarction of portion of the brainstem or cerebellum with swelling, hemorrhage, and death. Occlusion of the pica causes an infarct in the lateral medulla, which is going to supply dorsal to the inferior olivary nucleus. The syndrome of occlusion of pica, which is referred to as lateral medullary syndrome. Now, this is something which we should know. And as we have studied the anatomy, now we know that it's supplied some areas. So it's going to cause ipsilateral numbness of the face, and it's going to be caused by the injury to the spinal tracts of the trigeminal. Loss of pain and temperature on the lateral half of the body, and it's going to be caused by damage to the spinal column. Dysphagia, dysarthria, and hoarseness as a result of homolateral weakness of the palate, pharynx, vocal cord, and occasionally the sternocleidomastoid muscle caused by lesion in the nucleus ambiguus. Ataxia, dizziness, vertigo, nystagmus, and homolateral cerebellar signs, which is going to be caused by damage to the vestibular nucleus. Cerebellar tracts in the brainstem and the cerebellum, and ipsilateral Horner syndrome caused by disruption of the oculosympathetic fibers in the lateral medullary reticular substance. And vomiting, which is caused by involvement of the nucleus and tractus solitarius. Thank you.
Thank you, Dr. Areeba, for a detailed presentation. Do you have the angio slides as well that was suggested by Dr. Misbah? So I would request Dr. Misbah to join as well and give his expert opinion. Dr. Misbah and Dr. Areeba will explain the angios. Dr. Misbah, are you with us? Dr. Misbah, can you unmute yourself, please?
Hello?
Hello, yes. You're audible now,
Yes,
sir.
Yeah, okay. So I think Areeba has given a very good and detailed presentation of the anatomy. And Areeba, you can first show that lateral image of your anatomical section and then the lateral image of the angio. Yes.
So showing the lateral image of the presentation would be a little difficult because she'll have to close this one then.
Which one?
You can proceed, Dr. Misbah.
Okay. Areeba, now what you have told in that lateral image, so try to explain regarding that in the similar image.
Yes, sir. As we can see that this is a lateral image of angiogram, and we can see the filling of the vertebral artery we can see the origin of the PICA here.
Yes.
This area. And as we can see that it's make a tortuous course. It has a caudal loop, and then it's going to go upward and make a cranial loop. And then it's going to supply the suboccipital surface of the cerebellum, as we can see here. We can also appreciate the joining and making of a basilar artery here. And then its division into the superior cerebellar artery.
The top one, the red arrow which is marked, is that posterior cerebral artery, right?
Yes, sir.
Yes. This one is the posterior cerebral artery, and this one, yeah, the one which is below to it, come a bit more below, inferior to that, where that white arrow is inferior, where there is the white arrow. Yes, this one. Yes, this one. Right. So now on the anterior images, can we go to the anterior images? Yes. Do you also have that oblique image? Now here in this anterior image, yes, that red arrow which you seen is the posterior cerebral artery on the left side, and that blue one is what? Areeba, what should be the blue one?
Posterior cerebral
Yes,
artery.
this one. This is the, yes, on the right side. And the one which is just inferior to the posterior cerebral is the superior cerebral. Yes, this one is the superior cerebellar artery.
So there's some confusion among the participants. Areeba, can you go back to the first lateral image? Dr. Pravat has some questions. So yes. The red. So you know the red artery is the posterior cerebral artery.
Yes, and the blue one is also the posterior cerebral
on the right side, and the white artery is the superior cerebral.
Yeah, the one inferior to the, yes, this one is that superior cerebellar artery. Not this one. Yeah, this one opposite side. The one originating just above. Yes, go a bit up. Yes, this one. This one is the superior cerebellar artery.
And can you show the PICA again? So this is the PICA.
Yes, this
you
is
can see
the
the caudal loop. You can see the caudal loop, and then the cranial loop,
and then the cranial. Yeah, and then the cortical branches also.
Okay. Can you go back to the other images that you were explaining?
Now, Areeba, you can show that oblique image. This is also the lateral one, the oblique one, which you had taken. This is the frontal one, the oblique one. Okay, even no, go back. Next image. You didn't include that oblique image. Next. Okay, stop here. Now this is that anterior image. So that black arrowhead where the PICA is written is that origin of the PICA. Yes, this one from the vertebral artery.
So, Areeba, can you just give an explanation, and Dr. Misbah will add in if required.
Okay, sir. This is the anterior image, and we can see the two vertebral arteries that are rising from here, making a course over the C1. And as we can see, they both join together. Here, they will join together vertebro-basilar junction to form the basilar artery. Then the two basilar artery at its end is going to divide into the two posterior cerebellar arteries on the right and on the left. cerebral arteries, posterior cerebral arteries. And the artery that is going to be arising just beneath that division is the superior cerebellar artery, SCA, as seen here and here. Then the another branch which arises from the basilar artery is PICA. And as we can see, PICA usually arises from the vertebral artery on the both sides.
ICA also originates from the basilar artery.
Yes,
Sometimes.
Sometimes from the vertebral artery.
Sometimes from the vertebral artery. Like PICA, which usually originates from the vertebral, but sometimes it can originate from the basilar.
So, Areeba, can you move on to your next image and explain?
Yes, sir. This we have done previously. Now move on to this lateral image. As we can see, filling from the vertebral artery, we can see the origin of the PICA, the first branch that is going to be filled after filling the vertebral artery. We can see it's going to make a caudal loop and then move up, make a cranial loop, seeing its tortuous course, and then it's going to supply the cortical surface, the suboccipital surface of the cerebellum. The next artery that will arise will be the ICA and then the superior cerebellar artery.
Move on to the next image. Yeah.
And frontal projection, we can see the filling from the left vertebral artery. We can see the origin of the PICA, the first branch that is going to be originate after filling the vertebral artery. We can see that it move forward. This blue arrow is ICA, if I'm not wrong, and this will be the superior cerebellar artery. And just when basilar artery is going to end, it will divide into two posterior cerebral arteries.
Yes, right.
Move on to your next image. Are these angios?
Yes, sir.
Can you play them?
So this is an angio, and as we can see the filling from the left vertebral artery, we can see the basilar artery dividing into two posterior cerebral arteries here. We can see the filling of the superior cerebellar artery here and the PICA here. And this is arterial face, the PICA here, supplying giving the cortical branches.
Dr. Misbah, what sort of a view is this?
This is the oblique view.
This is the oblique.
You see, you see it better in the lateral view, and sometimes in the oblique view, you can see the origin better. So this is the oblique view.
Can you show the ICA here, Dr. Areeba?
It's bit faintly visualized. Yes, right. Yeah, this is the ICA on the right side, and it's the ICA on the right side, and the left side similar it's the same level on the left side. Yes.
So when you do angios, angiograph and angio, you say it's not complete till you see both PICAs. Is that true?
Yes, because sometimes you see the reflex on the right side, and if it's not visible, like in this image, you don't see the reflex on the right side. So if it's not image and it is indicated, then you will have to cannulate the vertebral artery of that side and take a run from that side. But sometimes if the cord is tortuous and the vessels are tortuous and it's not indicated, then you can skip it.
So, Dr. can you move to the next angio? This is an oblique view as well?
This is the lateral view.
This is the lateral view. So how do you differentiate between an oblique and a lateral? Looks a little
By the projection? No, the difference, you can see the loop here, anterior and posterior divisions very clearly, and even the shape of here. And in this, you can see that loop of the pica is bit clear as compared to the oblique, and you can see it going posteriorly. And similarly, superiorly, you can see the posterior cerebral artery, which is going from anterior to posterior, like this one, in a rather straighter course.
Okay. So, Areeba, what do you want to show in this image?
So the course of the pica, the tortuous one.
Yeah, this is the course of pica.
Let's make a cranial loop, a caudal loop, and then it supplies the give on many branches. It bifurcates a medial trunk and a lateral trunk.
So this was the this is the frontal
No,
projection.
you can see this is the frontal projection.
Okay. So, Areeba, can you explain?
Yes, sir. We can see the filling from the vertebral artery. We can see joined together to form a basilar artery, divides into two posterior cerebral artery. At the end, the superior cerebellar artery originating before its bifurcation, and on the here and here, and we can see pica here, which is kind of a little obscured by the tag.
Shall I move on to your next image if you have any?
I think she has explained the images on angio, and we have seen projections
yes.
on.
So thank you, Dr. Areeba, for your detailed presentation on angio. If there are any questions from Dr. Misbah, this is the time to use the chat box. I thank Dr. Misbah again for giving us time this presentation, and I see they're not. Since there are no questions, I think we will end this session today. We'll thank you, Dr. Misbah, for joining us. We'd like to have you next time as well.
Saad, what we can do that resident can come a bit earlier rather than just a day before, and if the resident can show me the presentation they are making, so I can tell that resident about the images on angio as well. So that
what we can do is we will after we finish all the vessels, we will have a separate session for angio where you can show all.
No, I think it's better like this one, in which because it's better that we read the vessel and see the angio at the same time. So that will give a better. So if the resident can coordinate with me a bit earlier, so we can tally those things on angio as well, and then they'll be in a better position to explain them. But Areeba did a good job, so I think it was good.
Thank you, Dr. Misbah. Thank you, everyone, for joining. Dr. Areeba, great job. We'll see you next week. Thank you.
Thank you. Oh, thank you.